Our next speaker today is Dr. Chris Gyngell, Team Leader of the Biomedical Ethics Research Group at Murdoch Children's Research Institute and the University of Melbourne. His research interests lie primarily in the ethical implications of biotechnologies and the philosophy of health and disease. He'll be speaking to us today about measuring the value of a life. Thank you, Dr. Gyngell.
So I want to first of all thank Richard for inviting me to speak today about this wonderful event, and I've been really touched so far to hear the stories so far. What I really want to do is to give a sort of an ethical and philosophical sort of perspective on the main question that we're here today, which is how do you value a life? How do you measure the value of life? And Richard put it well before, it's how do you put a price on something that is priceless? And if you asked most people, how do you measure the value of life? What is the value of life? They will tell you it's infinite. They will say you can't put a value on it. In fact, they might even say it's insulting to try and put a value on life. And you can see why that is. People go to extraordinary lengths to preserve their survival. I've got two examples here. These are a tiny little bit gruesome, so I'm giving you all a trigger warning. But I want to show you that lengths that some people go to for their own lives. So the first one is Aaron Ralston. Aaron Ralston's story has been in a movie called 127 Hours. So if you've seen that, you know where I'm going. He was out hiking one day. A boulder fell on his arm. He was trapped there for 5 days. The only way he could get out was to break his arm in 2 places and use a penknife that he had to cut through all his nerves and then get out. And find someone, and he was alive today. Then there's Julianne Kopke. She was the sole survivor of a plane crash that crashed in the Amazon rainforest. She was by herself. She had several broken bones and several infected wounds. She walked for 10 days to find a local tribe and managed to get out and live today. Now, if you ask them, how much of is your life worth? They're going to say, it is priceless. There is no value on it. And it's not just our own lives that we put this immeasurable value on. We put it on the lives of those very close to us, and including our children. There's countless stories like Aaron's and Julianne's about people going to great lengths to save the lives of their children. But rather than go through those, I'll just tell you a statistic that in the US, 1/5 of all bankruptcies are caused by an illness in a child, so people paying for medical care for their children. And I think that shows you, and in some of the stories that we heard earlier today, people will go to all lengths to save their children. They will go to anything possible. My brother last year passed away from esophageal cancer, and I know that our family would have done anything at all to keep him around for a few more years. So we've got this personal value of life, which we can't put a value on. But unfortunately, things get very, very complex when you go outside this personal context about surviving a plane crash or being trapped and go into this more difficult context in society where all of our choices have trade-offs. It seems clear that if we just prioritize life, we gave it an infinite value, we would live in a very, very different society that we may not like. For instance, many people die on the roads every year. Hundreds of people die. If we wanted to prevent all of those deaths, we could either put a speed limit of 5 kilometres every hour, we could stop people driving, but we don't think we want to do that because sometimes we care more about things than just preventing death. And this is, I think, is shown too with our experience with the COVID-19 pandemic. We could try and ensure no one ever dies of an infectious disease by doing lockdowns each flu season and putting these great restrictions on travel, but then we give up so much other parts of our life that we want. So this is the question, money that we spend on healthcare is money we can't spend on other things that we might think are important in life, such as education, such as the environment and arts. So this then becomes the question is how much of these other things we would give up for a life in a policy context? How can we define the tradable value of life. And this has been a challenge for governments for decades. And there's been a lot of different ways to attempt to do it. The first attempt to put a dollar value in life was in the 70s and 80s and done by economics. And their thinking was this: well, if someone dies, when they're 30, well, then they can't work for the next 40 years, so they're not going to be contributing to the economy. So we can put a value on their life by what their lifetime earnings would be. And how they did this, they said, well, this is the average lifetime earnings for people in a population, and this is what your value is of your life. At the time, that was around $300,000 in the early 80s, and now that would equate to about $1 million. This is a very, very low economic value to put on life, and it led to some crazy decisions. They did an analysis where they had all these hazardous chemicals that were selling without warnings. So they didn't have those labels that you can see down there. And they, using this value of life, they figured out, well, we can save about 5,000 lives a year. It's going to cost about 1.5 billion, but the labelling is going to cost $2 billion, so we're not going to put these labels on these hazardous chemicals. And this raised alarm bells. They're thinking, are we actually doing this right? And it led to this other methodology for calculating life. And that is, what are people willing to pay to avoid risk to their death? So some jobs carry risks that other jobs don't. For example, some types of construction, you're going to be working up high in high-rise buildings, you're more likely to have an accident than in other forms of construction. So they thought about, well, how much do I need to pay someone to take on that 1 in 1,000 risk or 1 in 100 risk to their job? And if you do that, you see about how much people are willing to pay to avoid risk to their life, you get this other calculation, which is much higher. So in the US, the calculation I found was about 8.7 million. In Australia, they did one at 7.3. So apparently Americans value their lives slightly more than Australians do. But don't know why, but that's just what they do. Another strategy that we've heard a little bit today is to take this concept of a quality adjusted life year. So that is, how much value is living in 1 year of good health. And this is used by health systems around the world to sort of value these health treatments. If you look at the Australian value, which I think is about $50,000 or $60,000 per QALY, you average that out by an average lifespan, some of which won't be spent in good health, you get around $3.2 million. All of these have shortfalls, and it's clear that we're just sort of trying to estimate a sort of tradable value of life that you can use in policy decisions, not the intrinsic value of life. And I've been very encouraged to read the Counting of Cost report that really measures these other things that aren't captured in these things. And it's the value of a mother supporting their children, the value of just people in their community and what a death can do, the flow-on effects to others. So we're in this hard spot, I think, where we're not actually capturing these full sort of values of death. Now, I'm an ethicist by training, so I want to talk about some of the interesting ethical issues that arise in valuing with the sort of time I have available. I've got a picture here of hopefully you remember a few years ago where there was some soccer players in Thailand trapped in a mine. There were 13 trapped down there. It was a worldwide event. People were very concerned. Countries from around the world flew resources there. They flew special equipment. Elon Musk was nearly going to make a special submarine at some point. Everyone was invested on saving these children, and the cost didn't seem to matter. So when Australia was giving resources to help the rescue, they weren't asking, what is our return on investment? What is going to happen? We were asking, what can we do to save these people? Now, you feel like a bit of a mean person to suggest, but people did at the time, well, what else could we do with this money? The most cost-effective way to save a life in the world that we have today is to give money to the Against Malaria Foundation, which provides mosquito nets to places in Africa. So they figured out that if you get more mosquito nets, for around $3,500, you will reduce the amount of deaths by 1 in the next malaria season. So you can pay $3,500 to save someone from malaria. Now, we don't sort of run off and do this. We don't have the same emotional reaction to the potential malaria victims you could save as we do to the to the trapped soccer players. And this is talked a lot about in moral philosophy, and it's called the problem of identified and statistical victims. So if we know someone's there and someone's dying, we're much more psychologically and much more motivated to try and save their life in comparison to when they're a statistical victim. This comes up in medicine too. So some of the most expensive medicines today are these new gene therapies that are coming out that so for example, there's a horrible childhood illness called spinal muscular atrophy, which causes death in childhood as the motor neurons die. There is now a treatment. It's $2.1 million for a treatment for a gene therapy. But with that same $2.1 million, you could invest in genetic screening technologies and IVF and prevent a lot more cases of spinal muscular atrophy than you can with that one treatment. So the question is, should we be doing this? Are the lives of the Thai soccer players actually more valuable than the statistical lives of the malaria patients, or are they not? And different ethical theories give you different conclusions. So a very common ethical theory is utilitarianism, which basically would just say a life is a life. It doesn't matter if it's a trapped soccer player or someone from Mosquito. We owe them the same, and therefore we should do a cost-effective model to this. But another theory is saying, no, we actually owe more to people who are really vulnerable, to people who are at risk, to people who are dying, and we show our respect for humanity and humankind by rescuing people when they're in need, and that we should have this approach to it. So I'm not going to answer that, and just show you the different perspectives. So another really important question, and this will come up with the social return on investment too, is do we value all lives equally? So again, a really central tenet of a lot of philosophies around the world is, well, a life is a life. You know, we're all lives are equal, they're all got the same inherent worth. But some of these economic things will not put an equal value on human life. And particularly, you know, if someone's elderly, if someone's in their 80s and they don't have a lot of life expectancy left, and maybe they're not, you know, interacting with a lot of people, then maybe they won't have that same social return on investment in someone who's much, much younger. So we have to ask ourselves, you know, are we comfortable with saying that some people's lives are actually worth more than other people's lives? This question gets caught up in another area of bioethics, which is really interesting, and again came to the front in the COVID-19 pandemic. And this is, who do we give priority to when there's limited resources? Early in the COVID-19 pandemic, there was a massive shortage of ventilators, and a lot of people needed ventilators. Hospitals were faced with this question: who should I give this ventilator to? And you've got various options. You could give it to the sickest person. Often these are more elderly people who are in the worst state, and some theories of ethics thinks, yes, we should give priority to the worst off, give it to the sickest person. Problem is, if you have that policy, the sickest people tend to use the ventilator for much, much longer than other healthier people, and you'll end up treating less people over that time than if you treated people who were maybe not as sick, but would need the ventilator for less time. Another question came up, what about healthcare workers who need it? Should we prioritise healthcare workers because then they can go out and help other people and have this greater social effect? So all of these questions were raised to the fore in the COVID-19 pandemic, and we can see how they're going to affect these health spending questions too. So all of these ethical issues also affect basic health spending at a system level and how we should go about it. So I've got this graph here, which is life expectancy versus health expenditure. And you can see USA is a way outlier. So they spend a lot on health, but they don't get a lot of returns in terms of health expectancy. Often I'll see these graphs and, you know, it's critical of the US system. It's like, oh, silly US people, like, what are they doing? They're spending money and they're not getting health systems. But it's really it's a different approach to valuing. And basically, in the US system, they don't think about cost effectiveness. They won't rule a treatment out because it's not cost effective. Their approach is, if you've got coverage, if you're in, then you're in. We're going to treat you like the Thai soccer players. Even if you get really sick and it's expensive to get you out, we're going to do it. The flip side of that is that you actually end up treating less people. So a lot of other health systems, will treat you more like a statistical life, whereas they will apply a cost-effective measurement to your treatment, and if it's not cost-effective, then they're not going to treat you. So this is a sort of difference in philosophy about how you go about cost spending. Recently, there's also been a few other approaches to how you should spend money. So approach that one of my colleagues has come up with is called cost equivalence rather than cost effectiveness. So the motivation for this is that actually when you do a cost effectiveness measure and you only treat people if the sickness they have has a cost effective treatment, it can be unfair to really a lot of people because it basically comes down to luck and to which resource that you get. So say you're very, very healthy your whole life and then you happen to get a rare cancer and then it is not a cost effective to treatment and the government says you can't have it. Well, that sort of seems unfair if there are other people who have had multiple illnesses, all of which were deemed cost effective. So this approach of cost equivalence would be that, well, everyone should get at least as much money as the effective treatment gets. So basically, everyone would get a fair access to these resources no matter what particular illness that they had. And the last thing I wanted to talk about was this, what do we value in terms of illnesses and how do we value the badness of death? So some treatments might be very cost effective, but they're only treating very, very minor sort of illnesses. So you can say that, a lot of people might have eczema or a lot of people might get headaches. Say you could have an eczema treatment that cured millions of people and gave them this sort of little benefit. Is that really more beneficial than sort of saving one lives? Sometimes we ask ourselves, how many cases of eczema would you need to prevent to save one life? And again, a lot of the ethical perspectives, and I guess mine would be, I'm not sure if there's any number of cases of eczema or this mild thing. But on a cost effectiveness, you will get to this point where actually, let's just treat these easier to treat things rather than the life-saving things. So that's actually all I had. So thank you very much all.